So we'll be talking more on a guideline based. I mean, the latest was the European guideline which came in 2022, which guide us for the management of some group of cases where the chance of getting sudden cardiac death is more. So how can we prevent that sudden cardiac death? That's what we are going to discuss in the next few minutes. So we know that sudden cardiac death is not uncommon nowadays. I mean, we are looking at a lot of cases, a lot of celebrities, sportsmen, people are dying because of sudden cardiac death. And many a times we don't know the reason, and we may not have managed them, or we may have missed them. So what is sudden cardiac death? So it is a most challenging presentation of cardiovascular disease, and it accounts for millions of deaths. And we know that out of hospital cardiac arrest is having very poor survival, less than 10%. And the problem with the SCD is that it is sudden and rapid, and it gives very limited opportunity for doing some intervention in them, or to make them survive. And therefore, strategies have focused on trying to identify them well ahead of sudden cardiac events. I mean, before the SCD events happens, we need to pick up them and treat them. So I have point number 1, and I will be concentrating on ischemic cardiomyopathy here. Here is a case, 67-year male, old enteral MI. He has a LED stent. His ejection fraction is 30%. His NYHA class 2. And he has a history of palpitation and pre-syncope. I'm going to show the ECG1. So if you see ECG1, there is a Q wave in V1 to V5. So and Q RBPP in V1. So this patient is having actually all enteral MI, and we know that looking at the ECG, he is having a scar into the enteral wall and with the ejection fraction of 30%. And he had this ECG. So it's a wide complex tachycardia. Very simple. It's a ventricular tachycardia, sustained monomorphic VT. Okay, so it's a scar VT in an ischemic cardiomyopathy. Now, how to manage this case? We know that this patient has to have an ICD defibrillator implantation. So I implanted ICD in this patient for prevention from arrhythmic death in this patient. So what guideline tells us? I mean, ICD therapy is recommended in patients who have history of VTVF. We know that they have to have ICD, but which all other patients with ischemic cardiomyopathy are there where ICD is recommended? So these are other indications. Whenever EF is less than 30%, yes, ICD is recommended as a class 1 indication for primary prophylaxis of ICD. Then if EF is less than 35% and class 2 to 3 NYHA, more than 3 months of OMT, they should have a ICD implantation. And then those patients whose ejection fraction is less than 40%. So these are cases where it is supposed something like a 35 to 40% ejection fraction, and they have ECG which is showing non-sustained ventricular tachycardia. So those NSVT patients should be subjected to EP study, means a VT induction study, and if the VT induction study shows that there is inducible sustained monomorphic VT on EP study, these patients should also have a ICD defibrillator implantation for sudden cardiac death. And then what is the role of catheter ablation in these patients? So catheter ablation is again recommended in patients who have a recurrent sustained monomorphic VT, or those patients who have already ICD and they are getting again and again ICD shocks because of monomorphic VT. These patients should be subjected to catheter ablation when they are not getting under control with codaron or amiodarone tablet. So my point 2 is again a ventricular tachycardia, but here it is idiopathic ventricular tachycardia. Here it is not a scar VT or a cardiomyopathy. What to do? So case 1, a 25 male, normal echo, normal angiography, having palpitation, and this was the ECG. So I mean, whenever we look at the wide complex tachycardia ECG, we need to look at the morphology in all 12 lead to identify the arrhythmia focus. I mean, from where the arrhythmia is arising, whether it's LV, whether it's RV, whether it is OT, whether it's papillary muscle, whether it is a vesicle, or whether it is a mitral annular. So from where the VT, or whether it is a moderator bend. So which part of the ventricle this VT is arising from, that is to be localized by looking at the morphology in the ECG. So when I meticulously localize this ECG, for me, this ECG is, this VT is arising from right ventricle, and it is arising from RV OT, outward VT. Now, I know that if the echo is normal and the OT VT, it's an idiopathic VT where the structural heart is normal. So what should be management for these cases? Then another patient is a 35 lady, echo normal, angiography normal, and again she has a palpitation, and this was the ECG. Now again, the ECG morphology if we look at, So this ECG is a right bundle branch morphology ECG with a superior axis. So I know that looking at the ECG morphology and character of QRS complex, this VT is arising from posterior fascicle. So posterior fascicular VT and RV outflow tract VTs. These are the two VTs. There are a lot of other VTs also, but these are idiopathic VTs. And here patient should not have ICD implantation because these are not the indication for ICD according to the ESC guidelines. So what is the treatment here? The treatment is catheter ablation. So catheter ablation is recommended as the first line treatment for these VTs which are idiopathic for management. And yes, there are drugs also like beta blocker and dihydropyridine CCBs like verapamil. So verapamil can also be given to these patients. But whenever we think that this VT does not look like idiopathic, we should always go for a cardiac MRI to again confirm the structural heart is whether normal or abnormal. Okay. So point 3 is now idiopathic PVCs. So idiopathic PVCs, I mean, here is a case 1, a 30-year-old lady, ejection fraction of 45%. Angiography is normal, MRI is normal. Her Holter was done and that is showing PVC of around 25%. She is asymptomatic. I mean, whether we should leave her alone with the PVC because she don't have any symptoms. How to manage this case who has a 25% PVC with a normal, I mean, with an EF of 45%. So the ECG was done. Now ECG was showing, you can see there are PVC, there are couplets, there are bigeminis. Now again we have to meticulously look at the morphology of the QRS, and again if I meticulously analyze, I feel that this VPC is arising from right ventricle and it is arising from right ventricular outflow tract. Now this VT is again from the RVOT. Now I know that this RVOT VT with a normal, with a MRI normal, this patient is, it's an idiopathic PVCs. Now, whether I should go ahead and do something for this patient, so that depends on now Holter. So when we did Holter was showing 25% PVC burden, so it's a very high PVC burden. And with an EF of 45%, that suggests that this patient has actually a PVC-induced cardiomyopathy. Now, if this patient we don't treat properly, his EF will worsen over the years, like from 45 to 40, 35. So we need to remove these PVCs. And then this is another case. It's a case 2, 40-year male. Normal echo, normal angio, but here there is palpitation and syncope also. Very important symptom is syncope in this patient. Now if we see at the PVC ECG, it is again a 12-channel ECG and it's a PVC with a trigeminate. We can see every third beat is a PVC. So every third beat is a PVC, and we can see the morphology in V1 is a right bundle branch morphology, and if you see the limblets, it's a superior axis. So this PVC is again going from fascicle or a Purkinje PVCs. But what is the most important here is the coupling interval. If you see the coupling interval of this PVC, it is a very short couple PVC where the PVC is almost falling on T wave. You can see the PVC is falling on the previous T wave. So this can lead to R on T phenomenon, and this R on T and a short couple PVC can lead to polymorphic VT, and this polymorphic VT can lead to sudden cardiac death. So these are the two patients, how to manage them. So what is the guideline? So guideline tells that catheter ablation is recommended as the first line treatment for symptomatic idiopathic PVCs when there is high PVC burden on Holter, that is more than 15 to 20% PVC burden, patients who are significantly symptomatic, malignant forms, especially that short couple PVC or those PVCs associated having history of syncope or a PVC triggered VT or VF. Or if the PVC is associated with LV dysfunction, it can be a PVC induced cardiomyopathy, or it can be PVC worsened cardiomyopathy also. Those who are already having a cardiomyopathy, if they develop PVC over and above cardiomyopathy, his EF will worsen more. It will go from 35 to 25. That is known as PVC worsened cardiomyopathy. Where we remove the PVCs, his EF may come back from 25 to 35, will get a symptomatic improvement. So these are the patients where catheter ablation is recommended as the first line treatment of choice. Now, point number 4 is a non-ischemic dilated cardiomyopathy. We discussed in the previous session a lot about non-ischemic dilated cardiomyopathy. So now, what to do? What guideline tells us about the management? Now, again, a case, a 55-year lady, dilated cardiomyopathy, normal coronaries, EF is 40%, NYH class 2, no family history. She had unexplained syncope. Now the question is that here EF is 40%. Now standard guideline tells that less than 35% EF we can go for ICD, but now EF is 40%. What to do? Now when the ECG was done, this was the ECG which is showing sinus rhythm, somewhat LVH type of pattern, and there is little bit wider QRS duration is around 130 millisecond. Now how to restratify this patient and how to manage this patient? So we need to go for a cardiac MRI for this patient. So this is further imaging of this patient, which we did. And cardiac MRI was showing, you can see, I mean, it's tough to show here. I don't have a pointer, but there are mid-myocardial late gadolinium enhancement that is suggestive of a myocardial scar. So there was a significant myocardial scarring of the same patient in cardiac MRI. So myocardial scarring will lead us to the further treatment idea. So according to the guidelines, I will show the guideline next slide, but according to the guideline, this patient should have a ICD implantation. But because this patient was not having, was not ready to have ICD implantation, so he went back. Patient went back, but then what happened? On one day, she came back with the this one. So this patient was having unexplained syncope. She never had any arrhythmias, but this was the rhythm with which she came back. So that suggests that what we suspected from cardiac MRI, that she has significant myocardial scarring. This was the reason we advised her ICD that she might have this arrhythmia in future, and that can lead to sudden cardiac death. So this patient actually should have ICD before this event, but she was not ready. But then she was lucky enough to come to the hospital. She could reach to the hospital. This was cardioverted, and finally she underwent ICD implantation. So that's how we going ahead with the guideline, like what ESC tells us when there is a non-ischemic dilated cardiomyopathy. First one is a risk stratification. Genetic testing should be done, and cardiac MRI should always be done for myocardial scar assessment in all non-ischemic dilated cardiomyopathy. So cardiac MRI, I always go for all my dilated cardiomyopathy patients. Genetic testing depends on the features, like if there is a conduction system disease, or young age, or those who have a family history of cardiomyopathy or SCD, I go for a genetic analysis also. So what is the recommendation of ICD therapy to prevent sudden cardiac death in all these patients? Now we know that those patients who have history of VTVF, we have to put ICD, but what about those patients who don't have any history of VTVF, whether to put ICD as a primary prophylaxis or not? So those patients whose EF is less than or equal to 35% with NIHA class 2 to 3, we should have a ICD implantation. And then, this is very important, those patients whose EF is less than 50%, suppose a patient whose EF is 45%, now whether we should put ICD in him or not. Now, any patient whose EF is less than 50%, if there are more than or equal to 2 risk factors, we have to put ICD. So which are all the 2 factors? So one is unexplained syncope, second myocardial scar on cardiac MRI, and that's why we should go for cardiac MRI in each and every dilated cardiomyopathy patient. And if there is more than 20% of LV mass, third, subject them to EP study, and if there is any inducible sustained monomorphic VT, and fourth is a pathogenic mutation. That's why genetic testing is also very important whenever there is a family history or a young DCM. So if out of these 4 genes, so these 4 risk factors are there, if any of the 2 risk factors are there and the patient's EF is suppose 45%, still this patient should have ICD implantation to prevent him from sudden cardiac death. Then this LMNA gene is also, lamin A gene is also having a very high risk of getting sudden cardiac death. If we found out this gene, whatever is the ejection fraction, this patient should have ICD implantation for sudden cardiac death prevention. And 3D mapping, I'm not going, but I'm going for the last scenario. I have 2 minutes left. So that is point number 5 for hypertrophic cardiomyopathy patient. What the guideline tells. So there is a case example, a 30-year male, HOCM, but mild LVOT obstruction. He has a family history of sudden cardiac death. Echo was done. Echo is showing 55% EF. Maximum interventricular septum is 28 mm. LA is 40 mm. His Holter was done. Holter is not showing any NSVT. There are no NSVTs on Holter. His angiography was done. No stenosis. NYHA class 2. There is no syncope also. So here, no syncope, no NSVT. And IVS max is 28 mm. But he has family history of sudden cardiac death, and there is only mild LVOT obstruction. Now, how to go ahead about this patient, whether he needs any further treatment or not? So, if you see the ECG is showing the classical feature of cardiomyopathy in form of bizarre QRS complex and pathological Q waves. Echo was done. Echo was showing, you can see the septal hypertrophy. There was 28 mm septal wall thickness. It was asymmetrical. And what to do ahead? So this patient, what ESC guideline tells that you have to go for a HCM risk SCD calculator, and we have to calculate the risk of SCD of this patient by this calculator. So what I did, I calculated the SCD risk of this patient, I put all the parameters whichever are required, and what is it showing? You can see in the last box, risk of SCD at 5 years is 4.59%. So this patient is having almost 5% risk of death over the next 5 years. So what this risk tells us how to manage, we'll show in the next slide. So what we did, we did a cardiac MRI again. So I always go for cardiac MRI for all my cardiomyopathy patients. This patient also underwent a cardiac MRI, and cardiac MRI was showing significant myocardial transmural scarring of septum. So the scar burden was almost 20%. So this much data we have, and what I did, so I'll take last slide. So what I did, I implanted ICD into this patient for sudden cardiac death risk prevention. But why I did ICD? So that I will show into the last slide. So that is a recommendation from European Society of Cardiology. So SCD restratification, genetic testing and cardiac MRI should always be done in all hypertrophic cardiomyopathy patients. It's a class 1 indication for all the patients. Now, which patient should get an ICD? History of VTVF, everybody knows that anybody who has VF or VT, we have to put ICD. But which are those patients who does not have VTVF till now, but we have to put ICD as a primary prophylaxis? So this is there. So those patients whose age is more than or equal to 16 years, and that calculator which we calculated is showing the 5-year risk of SCD more than or equal to 6%. European Society of Cardiology tells that this patient should get a ICD implantation. And then age more than 16 or more than equal to 16 years, and the 5-year risk of SCD is 4 to 6%. So what to do when the risk is 4 to 6%? Our patient was having 4.8%. So he is falling into this criteria. Now, this patient with any of the below, which I am going to show, if it is there, then this patient should have again ICD implantation. So first cardiac MRI showing myocardial scarring more than 15% of LV mass. So we detected this on cardiac MRI, and that was the reason that we put a ICD in this patient, though he does not have VTVF till now. So to prevent a sudden cardiac death in future. What other things can be there? As Dr. Milind told just before some time. So whenever HCM with an EF of less than 50%, it is also a risk marker for sudden cardiac death. Then abnormal blood pressure response during exercise test, LV apical aneurysm, and presence of sarcomeric pathogenic mutations on genetic analysis. So out of these 5, if any of the one is there and calculated risk is between 4 to 6%, this patient should have an ICD implantation for a primary prophylaxis against sudden cardiac death. And those patients who are less than 16, pediatric group of the patients, there the risk score is different. So HCM risk kid score, again, if it is more than or equal to 6%, this patient should have a ICD implantation for sudden cardiac death prophylaxis. So that calculator was very simple. It's available online, ESC guideline. You just have to put few parameters, and that parameters will lead to this percentage. And according to this percentage, ICD indication is defined. Thank you.
ESCERS guidelines were published in 2019, and they again updated this year, just a few months ago. So this is fresh out of the press, and several things they have changed. I have tried to limit the situation so that all the primary care physicians can understand. Do you guys have those voting pads? I have several questions for you. So let's start with the clinical vignette. This is a 45-year-old female, has a history of SLE. She's on a mycophenolate for the skin manifestations, no cardiopulmonary complaints, no shortness of breath. Echo was done for the pulmonary hypertension screening, and RVSP, or right ventricular systolic pressure, estimated was between 30 to 35. Right heart cath was done, shown a mean pulmonary artery pressure of 19, wedge pressure of 10, and pulmonary vascular resistance 2 Woods unit. Does this patient has PAH, pulmonary arterial hypertension, according to the new classification? Yes or no? At least you have a 50% chance to be correct. Statistically. Okay. I think the correct answer is no. According to the new classification, there is no pulmonary arterial hypertension. So remember, the pulmonary hypertension definition altogether has been changed in 2019. At that time, this number, which was 25, has been changed to 20. And that change happened in 2019, not now. And the new definition included a change in a pulmonary vascular resistance more than 2 Woods unit. That number was actually more than 3 Woods unit before. So that has been changed in this 2022 guideline. So the definition of pulmonary arterial hypertension includes 3 different parameters: mean pulmonary artery pressure more than 20 or more than equal to 20, wedge less than or equal to 15, and the pulmonary vascular resistance more than 2 Woods units. So this is a new definition. We don't know what to do with the new definition, but I will show you a few more important, interesting examples. So same patient came to you again a year later Now she's 46 years old compared to 45. She's still having SLE and on mycophenolate. No cardiopulmonary manifestation still. Echo was again done, showed the RVSP of 30-35, and this time the right heart cath is showing mean pressure of 25, wedge pressure 10, pulmonary vascular resistance 1.5 Woods unit. So what is the diagnosis? Does she have a pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension, unclassified pulmonary hypertension, or a mixed pulmonary hypertension? This is also a new change in the new guideline. So based on the right heart catheterizing data, what is the correct diagnosis? Wow. Pre-capillary hypertension, that's what a lot of people are saying. Remember, just I showed you for a pre-capillary, also known as a pulmonary arterial hypertension, you need the pulmonary vascular resistance to be more than or equal to 2 Woods unit. Current vascular resistance is 1.5 Woods unit, so that will not classify for the PAH or a pre-capillary. The correct answer is actually unclassified. This category was not existing before. Now in a new classification, this is a category known as an unclassified pulmonary hypertension. And whenever the patient has an elevated mean pressure, more than 20 like last time, but the low PVR, so the vascular resistance is not yet increased, those people can be considered to have an unclassified pulmonary hypertension, and this is a new entity added in this new classification. Second case, this guy is a 65-year-old gentleman with a CAD, hypertension, cabbage and shortness of breath. I think you see this patient in a routine practice, came to you with NYHA class 2 shortness of breath. Echo was done for the pulmonary hypertension screening, showed the RVSP of 50. So the right heart cath was performed and the mean PA pressure is 30, wedge pressure is 20 and a pulmonary vascular resistance is a 1.5 Woods unit. What is the diagnosis? Pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension, unclassified PH or mixed PH. Excellent. I don't need any more intervention here. I think this is a classic post-capillary pulmonary hypertension. Just to go over the pre-capillary, meaning by the PAH or a pulmonary arterial hypertension, you need a vascular resistance more than 2 Woods unit. For a post-capillary or isolated post-capillary, that is the most common cause of the pulmonary hypertension, the vascular resistance is low. That is purely a flow-mediated pulmonary hypertension, and we'll talk about that in a second. Combined or a mixed pulmonary hypertension when the wedge pressure is high as well as the Woods unit are high. So when the wedge pressure is high but the Woods units are low, that's a pure post-capillary pulmonary hypertension, your left heart failure pulmonary hypertension. While the wedge pressure is high and the vascular resistance is high, that is the basically your mixed or the pre and post-capillary pulmonary hypertension. They also added this new, which was there before, they took it out and now again added with a different definition known as exercise pulmonary hypertension, when the mean pulmonary artery pressure divided the cardiac output slope between the rest and exercise is more than 3 millimeters. So between rest and between exercise, if there is a more than 3 millimeter of mercury difference, those people will be considered to have an exercise induced pulmonary hypertension. So the same patient who has the mean pressure of 30, wedge pressure is high, vascular resistance is low, what is the clinical classification? So we said it's a post-capillary. What is the clinical classification according to the diagnosis? Is it a group 1, group 2, group 3, group 4 or group 5? This should be again correct by 100%. So this is a group 2 pulmonary hypertension, and that is the most common cause of the pulmonary hypertension. Group 2, and these are the 5 groups. So the group 1 is a pulmonary arterial hypertension. We definitely need to understand the difference between PH and PAH. Group 1, if you guys remember from a long time ago, the classic pulmonary hypertension patient they used to give, the young female 20 or 30 years of age, comes with a shortness of breath, progressively worsen and significantly cripple. We used to label them as an idiopathic pulmonary hypertension or a primary pulmonary hypertension. That is a group 1 pulmonary hypertension in which the mean pressure is high, more than 20, wedge is low, and the resistance is high. Group 2 is basically the pulmonary hypertension due to left heart disease, and that is the most common cause of the pulmonary hypertension. Happens in more than 80 to some of the study shows even 85% of the patient who has an increased pressure on a right side secondary to increased pressure on a left side. Remember, the blood moves from a right ventricle via pulmonary artery into the lungs and from the lungs to the left atrium. So if a left atrial pressure goes up, the PA pressure must go up. And that is simply a left heart disease associated post-capillary pulmonary hypertension. If the people do not have a problem in the heart, but if they have a problem in a lung, for example, hypoxia, COPD, interstitial lung disease, that will also cause a pulmonary hypertension known as a group 3 pulmonary hypertension. Unfortunate few people after the pulmonary embolism will develop small clots and repeated clots. Those repeated clots can increase the pulmonary pressure, will be known as a pulmonary hypertension due to obstructions or the CTAF, chronic thromboembolic pulmonary hypertension, or a group 4 pulmonary hypertension. And a group 5 is an unclear mechanisms or multiple mechanisms. Now, what are the symptoms you guys are looking for? And of course, the dyspnea on exertion is the most common symptom, the fatigue and exhaustion because there is a low cardiac output. This is a new addition in a symptomatology known as a dyspnea when bending forward. I never heard this term before, is known as a bendopnea. You know, the people who are going to take the exam of the students or the residents should ask this question now. They of course can have a palpitation and the hemoptysis, which is a rare symptom. Very rarely they can have symptoms due to the dilated pulmonary artery. When the pulmonary artery is dilated, it can cause exertional chest pain, it can cause a hoarseness because it will compress the recurrent laryngeal nerve, or it can cause the wheezing because it will compress the left main bronchus. So I think those are the symptoms due to the dilated pulmonary artery, and I will show you a couple of pictures. People can have a signs of the pulmonary hypertension, for example, central or mixed or peripheral cyanosis. All of you guys are an excellent clinician and always going to find out the loud P2. You can have a right ventricular third heart sound because of a right ventricular failure. You can have a systolic murmur of the tricuspid regurgitation and diastolic murmur of the pulmonary regurgitation. People can have a signs and symptoms of the primary disease which is causing the pulmonary hypertension. For example, congenital cyanotic heart disease. So people can have a clubbing. People can have the murmur for the PDA. People can have a sequel of the CTAF and so forth and so on. Finally, when the disease progresses further, people can have a sign suggestive of a right ventricular forward failure. Remember, when the right ventricular backward failure, when the pressure is increasing in the right ventricle, it's going to increase in the IVC and SVC. So people can have a neck vein engorgement, people can have an engorgement of the IVC, abdominal distension, ascites, and finally paradigma. If the right ventricular forward failure happens, the right ventricular cardiac output will go down. So of course the left ventricular cardiac output will go down. So the people can have a low cardiac output signs like syncope or the dizziness and the cold extremities. So another case, like when you see the X-ray, what are you going to look? Because this is very common for you. You see probably 100 X-rays a day. Which of the following patient has a pulmonary hypertension looking at this X-ray? 1, 2 or both? Okay. Oh, I think the both patient has pulmonary hypertension. What you are seeing here, this is a dilated right descending pulmonary artery. If you can see my cursor, this is a right descending pulmonary artery or RDPA. If a diameter of a right descending pulmonary artery is more than 16 millimeter on X-ray, that is a very good sign to tell you that this patient has pulmonary hypertension. Here there is a huge pulmonary artery kind of aneurysm, and again you can see the dilated pulmonary artery on the right side also. So both of this patient has a possibility of pulmonary hypertension. If you guys look at the CT scan, the rough rule of thumb is that the impression of the aorta, this is aorta, usually is larger than the pulmonary artery. But if you see the pulmonary artery which is dilated than aorta, that's a straight away sign of the pulmonary hypertension. So again, when you are looking at a CT scan or X-ray, you are going to look for this particular signs. Finally, this is probably the last case. The 55-year-old guy who has an end-stage renal disease on hemodialysis with AV fistula, has a chronic shortness of breath, function class 2, 2D echo was done, RA was normal, RV was normal, LA is moderately enlarged, and the patient has a diastolic dysfunction of grade 2, EF is 55%. Right ventricular systolic pressure is 40. What is the next best action? Will you start this patient on sildenafil? Will you consider right heart cath? Will you consider bosentan? Or will you consider the HRCT and pulmonary function test? Okay, interesting. I think the correct answer is to consider right heart catheterization. Whenever you are doubting or trying to rule out the pulmonary arterial hypertension, group 1 pH, you cannot determine anything without the mean pulmonary artery pressure and the wedge pressure. So right heart catheterization becomes must before you think of a treatment. So in our patient, for example, right heart catheterization was done, and these are the numbers. The mean pulmonary artery pressure is 30, wedge pressure is 20, and the pulmonary vascular resistance is 1.5 Woods unit. Now you know what classification this is going to go for. So the question is, what is the next best action? Consider sildenafil, consider VQ scan, consider fluid removal, or consider bosentan. I think the correct answer is probably the consider fluid removal, because remember, this guy is a group 2 pulmonary hypertension, or the post capillary, because the wedge pressure is high, vascular resistance is low. So this is technically a group 2 or a left heart failure type of a pulmonary hypertension. And the best treatment for that is actually fluid removal. Now this patient has end-stage renal disease and he's on hemodialysis, so your conventional Lasix or bumetanide is not going to work. They need to remove the fluid, more and more fluid during the HD. So role of a PD, some of the people selected the sildenafil. The role of a sildenafil was significantly debatable, and this part was also changed in the new guideline. Whenever we have a heart failure with reduced ejection fraction, they do not recommend sildenafil because that was actually causing more problem. If we have a pulmonary hypertension, if we have a heart failure with preserved ejection fraction and the isolated post capillary, like my patient, they are not recommending PD5. When the people have a combined pre and post capillary pulmonary hypertension, this is the part which has been changed in this new guideline. They mentioned that we do not have enough data for a pro or the against, so we are not making any specific recommendation. But in some of the sildenafil studies, when the people have a mixed pulmonary hypertension, meaning by wedge pressure is high, but the vascular resistance is also high, those people have some improvement in a RV function and a quality of life at the 6 and 12 months. So they say that some of the studies are showing benefit, but the other studies are not showing benefit. So we do not recommend pro or the against of anything. While heart failure with a preserved ejection fraction and the vascular resistance is very high, for example 5 Woods unit, then you need an individualized approach. So I will stop here and I will say thank you very much.
Good evening everyone. This is the latest guideline which is recently been published, and probably all of you will be doing a sort of a pre-op assessment, and definitely is going to be very useful in your day-to-day practice. Now it's a very big guideline, so I'm not going to tell everything. There are so many sessions, but the important sessions which I want to focus right now is regarding the biomarker, use of biomarker. Antiplatelet, anticoagulation, we all should be knowing because most of our patients are undergoing surgery. Specific cardiac disease, I will just brief something, and diagnosis and management of post-op complication. Okay, how to diagnose early and how to treat. That is what I'm going to tell. Now, whenever you have a patient who is going in surgery, surgical risk can be reduced by surgeon by doing a laparoscopy thing or anesthesia, which can be a little bit minimized. But for us, it is more of a patient-related risk we have to focus. And we have to try to reduce the patient-related risk and identify it early so that we can have a better outcome. We have to identify there are certain low-risk procedures, less than 1%, like breast surgery, dental surgery, eye surgery. There are certain surgeries like head and neck surgery, intrathoracic surgery, hip surgery, spine surgery, which is intermediate. And there are certain surgeries which are very high risk, like duodenal surgery, liver resection, esophagectomy. These are the surgeries which are definitely going to be very high risk. There are various risk scores which are available. We can use whatever you are comfortable, and it is not in the guideline mentioned that which is better than the other risk score that we have to keep in mind. Now, this is a 60-over-year guy who is a diabetes smoker, not a known coronary artery disease patient. ECG is normal, echo is normal, not able to walk much. He has a plan for hip replacement, and what are the investigations to be done. ECG echo is fine, nothing more is required. Stress echo should be done before surgery as the patient is not able to walk. Coronary angiography because the patient is having diabetes, smoker, we want to be more sure it's a planned surgery, or we have to do a biomarker like troponin or anti-proBNP. Compared to the routine risk scores which we have, if you add either a troponin or anti-proBNP, definitely it improves the risk to this patient of mortality or a post-cardiac post-surgery patient having myocardial infarction, cardiac arrest or acute heart failure. So that is the important message I wanted to give, that troponins or anti-proBNP is a very useful thing. And that is the reason for pre-op assessment, it is class 1 indication. Okay, so you do a troponin in certain subset of patient. Okay, which are the subset of patient? More than 65-year-old with severe risk factors or an established coronary vascular disease, and patient is going either intermediate or high risk surgery. Okay, so that's an important message. If the patient is having risk factors or a coronary disease, biomarkers should be done preoperatively, and it is a class 1 indication according to the new guideline. What about the anti-proBNP? It is a class 2A guideline, especially if the patient is not able to walk much. So that also we have to keep in mind. What about the stress imaging? Stress imaging is a very useful test, especially you have a poor functional capacity, as that was the case in our patient, or patient is already having poor functional capacity and a high risk patient or cardiovascular disease. So these are the subset of patient where anti-proBNP and stress imaging also is to be done preoperatively if you really want to risk stratify this patient. Now we can give the answer. What should we be doing? ECG echo is fine. Stress echo before surgery, coronary angiography or a biomarker, and the answer probably so that is a good I think message you already have got, that biomarkers should be done in most of the patient, especially the troponin which should be done. Now, so the same patient who is planned for surgery, hip replacement after 1 month, but he has developed a chest pain 3 days prior to the surgery. What we should be doing? Whether get a fresh ECG and echo, if both are normal, go ahead for the planned surgery. If ECG and stress echo should be done, if both are normal, go ahead for the surgery. ECG, echo and biomarker should be done, and if all the 3 are normal, then only go for surgery, or you do a coronary angiogram and do intervention if it is required. So the message, the guideline, what they says, if there is an elective NCS and patient develops a chest pain prior to the surgery, we have to do according to a standard way of managing acute coronary syndrome. Similarly, if you can postpone the surgery, like our surgery is a planned surgery, we can wait for up to 3 months, then definitely we have to first focus on the chest pain, you have to evaluate the coronary disease and then go for the planned surgery. And if you're doing this intervention, a drug-coated stent, latest third generation drug stents are better than plain balloon angioplasty. So that is what we have to keep. The patient has undergone angioplasty because patient had chest pain, troponin was positive, there was a thrombus containing lesion, drug-eluting stents were put, patient was put discharged on aspirin, ticagrelor, statin and anti-diabetic drug that was empagliflozin and metformin was started. Now, till what time the surgery should be postponed? Because we know that it's a planned surgery and the patient has undergone intervention for acute coronary syndrome. Minimum of 3 months, 12 months, lifelong, or after till 1 month. So what the guideline says is, it has to be, if there is a procedure which has been done, coronary intervention for acute coronary syndrome, we have to postpone for 12 months. Okay, so that is the message. If it is done for elective angioplasty, then we can postpone it for, because our patient had acute coronary syndrome, so that is what the recommendation is there, that if there is a patient who has undergone coronary intervention and patient is on 2 antiplatelet agents, then minimum of 12 months, if the patient is undergone for acute coronary syndrome, we try to postpone. And at least 3 months, if it cannot be postponed more than, but at least try to postpone it for 3 months if it is possible. So angioplasty was done in this patient, and the surgery was basically postponed for 12 months. Unfortunately, the same patient developed acute cholecystitis impending perforation 15 days after stent implantation. Okay, and this requires an emergency surgery. So different situation, not a planned surgery, and patient is on aspirin or ticagrelor. What to do? Stop both antiplatelet for 4 to 5 days and get the surgery done. Stop only ticagrelor for 7 days and continue aspirin. bridge with LMWH and go ahead with the surgery, bridge with cangrelor and go ahead with the surgery, or stop ticagrelor 2 days prior to the surgery and continue the aspirin. So these are the options. We'll just discuss what is the recommendation. The recommendation if the patient is on dual antiplatelet agent and patient's bleeding risk is not high, okay, then we may continue dual antiplatelet like a dental surgery, eye surgery, and we can go ahead for that surgery. We should not stop. If the patient is having low bleeding, high bleeding risk, at the same time high thrombotic risk, like our patient who has undergone an angioplasty with drug-coated stent, thrombus contained lesion 15 days prior to the planned surgery. It's what we can call it's a very and the surgery, non-cardiac surgery also is required on the urgent basis. The best way to do is a bridge with the cangrelor. So cangrelor is an important molecule which can be used, and this is there are certain specific things like if there's a left main angioplasty, calcific block, bifurcation stenosis. These are the subset of patient that is high thrombotic risk, and we have to bridge. We cannot stop the second antiplatelet agent in this patient. Now, how we should be doing it? We have to stop prasugrel 7 days prior to the surgery or 4 or 5 days prior to the surgery. And if it is a ticagrelor, then we have to stop it for 3 or 4 days. Aspirin should be continued throughout the surgery. We have to start the infusion once you stop. So suppose you stop at prasugrel or ticagrelor, after 72 hours you have to start a cangrelor infusion. We have to continue the cangrelor infusion during the till the surgery. On the day of surgery, before 2 hours, we can stop the infusion. We finish the surgery, and after 2 hours, we can restart the cangrelor, and then later on we can switch over to the antiplatelet agent. So what is the answer in this patient? Stop antiplatelet for both the agent for 4 or 5 days. Stop elute ticagrelor, bridge with LMWH, bridge with cangrelor, and stop ticagrelor 2 days prior. As you know, patient has undergone stent implantation 15 days, and we cannot cover the surgery. So bridge with cangrelor is the best option. There is no concept of bridging with LMWH. Okay, when it's an antiplatelet agent we are stopping, it is going to be cangrelor. Now the same patient who has bridged now after 1 year, the patient has been planned for a standard hip replacement. Meanwhile, the patient had hypertension. Patient was put on amlodipine. There was some edema bilateral, probably because of amlodipine also. What we should be doing, what to understand the issue. The risk factor for this patient is diabetic, smoking and hypertension, known coronary disease, so we have to do definitely certain tests. Now the patient is also having edema, antiplatelet agent, how we should be following this and take care immediate and post-operative in this patient. Now what is standard recommendation? Smoking cessation 4 weeks prior to a planned surgery is very important. Okay, so if you don't do it, then there is always chance of wound infection or a post-operative complication, and there has to be a standard way of performing pre-op assessment 1 month prior to the non-cardiac surgery if it's a planned surgery. Okay, so we have to do because we need to re-stratify in most of the patient. Now this patient already having a coronary disease, and as I have told in the beginning, troponin is important. It is a class 1 indication which should be used not only before surgery but after post-operative on day 1 and day 3 also. I will just discuss that thing also. Anti-proBNP also should be done. It is a class 2 indication, and as the patient is having dyspnea and the peripheral edema, anti-proBNP also an important marker, and if it is high, definitely something needs to be done. So this patient, these are the tests which is done. ECG was normal, stress echo also was performed, and that was normal because the patient has no good walking. Anti-proBNP and troponin was always normal, so the surgery was planned. What should we be doing? We should be doing with continuing aspirin. Okay, so we can stop the second antiplatelet agent, but the aspirin should be continued throughout the surgery. These are the surgeries with the minor risk. There is a good classification which is given for the low risk bleeding surgery. And ticagrelor, if it is to be stopped, it is for 3 to 5 days. If it's a prasugrel, minimum of 7 days is to be stopped. So that is an important thing. What about the other therapy like beta blocker? If it is there, we have to continue. Statin, if it is there, like our patients, to be continued. If there is a RAS inhibitor, we have to stop on the day. It is a class 2 indication. And if it is patient is on empagliflozin SGLT inhibitor as our patient, we have to stop 3 days prior because many times the post-operative complications are high. Now, perioperative mortality is as such very high that we have to keep in mind. If you treat the coronary disease before planned surgery, definitely the outcome in better. That has been definitely it has been proved. Troponin post-operatively is very important. Now this is a patient 65 year, and we have to understand that troponin is if you want to detect a silent myocardial infarction post-MI, then troponin is very important. Now this is another patient, 82 year female surgery. Day 1 patient is normal. Day 2 there is a cardiac arrest. Troponin was done, it was very high, cath was done, there was significant quantity disease, angioplasty was done, but because of other complication, if you look at retrospectively, and day 1 if you do a troponin, it was 111. So previously it was normal and now it is 1-1. So it is definitely a perioperative injury or a perioperative MI which should be considered. So day before surgery, post-operative 1 day and post-operative 3 days are important if you really want to pick up these patients. Now this is the patient who has 40-year surgery. Troponin preoperative is normal. Post-operative there is a troponin on the day 1 which is very high. So you have to find out the cause. You have to look at the ECG. If it is ST elevation, it is probably with the ischemia. If it is ST depression, severe anemia also can cause a troponin high and the ECG changes. So we have to correct that and we have to find out some other causes and treat accordingly. So this is what needs to be done. As far as post-operative patient is concerned, we should not be giving a non-aspirin in this group of patient. What about the oral regulation post-operatively? That basically depends on which surgery is done and how the prolonged embolization is done. So that the patient wasn't put on rivaroxaban and the patient developed this thing. A minor wound infection post-operatively and patient needs to undergo a minor procedure. How do you manage this? So that also we have to keep in mind when the patient is on oral regulation. We have to know the half-life of the patient, and if you see it's warfarin, it is for about 5 days to have effect on. If it is other, then it is 7 days. For apixaban, dabigatran and rivaroxaban, it is 24 hours. So that also we have to keep in mind. So if the patient is undergoing this procedure on oral anticoagulation, here also we have to balance between the thrombotic risk and the bleeding risk. And if the bleeding risk also is high and thrombotic risk is also high, the bridging is very important, and that is what is recommended. This is what we should be doing because many of our patients will be on NOAC, okay, and undergoing surgery. If there is a high bleeding risk surgery, non-cardiac surgery, which is, we have to stop it for about 2 days. If it is low risk or intermediate risk, then it may be stopped on the day of the surgery because there is no bridging which is required, which is very classically required for warfarin or acetron. So that also we have to keep in mind. This is regarding, suppose the patient is the same patient who is an ejection fraction of 30%, okay, and he is going for non-cardiac surgery. Anti-pro-BNP level is very important in this group of patient. We have to optimize all anti-failure treatment, okay. All standard guideline therapy should be done before surgery, and volume status and organ perfusion is important. We have to take care during and post-operative in this patient. As far as severe aortic stenosis is concerned, we have to be very careful. If it's a planned surgery, aortic stenosis, severe symptomatic should be focused first, and we have to do either AVR or a TAVI, and then go ahead for the planned surgery. If it is similarly a severe mitral stenosis with significant pulmonary hypertension, which should be taken care first. If there is a severe AR or MR and LV is dilated, patient is symptomatic, that should be taken care first, and then planned surgery should be done. If there is a pulmonary hypertension, then also similarly we have to be very careful. Probably this is the last slide. So there is going to be interplay between a patient risk, a bleeding risk, a valvular heart disease, and the fluid or the stress which is occurring at the time of surgery. And we have to take care of all this during surgery to have good long-term, post-operative outcome, or if you really want to prevent cardiovascular complication in non-cardiac surgery. Thank you very much.
We will be discussing ACCHA guideline 2022 for heart failure. Now, this is the classification of heart failure by left ventricular ejection fraction, and as per this classification, FREF, that is heart failure with reduced ejection fraction, is when LVEF is less than 40%. Heart failure with improved ejection fraction is previous LVEF less than 40% and follow-up measurement of more than LVEF of more than 40%. Heart failure with mildly reduced ejection fraction is LVEF between 41 to 49, and HFpEF is heart failure with preserved ejection fraction with LVEF of more than 50%. And in both this, you have to have evidence of spontaneous or provocable increased LV filling pressure, that is elevated anti-pro-BNP or non-invasive and invasive hemodynamic measurement. We know the stages of heart failure by ACCHA, and now they say stage A is at risk for heart failure, where patients are at risk of heart failure but they are asymptomatic without signs of structural or functional heart disease or abnormal biomarkers. For example, patients with hypertension, diabetes, obesity, etc. Stage B is the pre-heart failure stage where patients are asymptomatic, but they have either structural heart disease or evidence of increased filling pressure. And stage C and D are symptomatic heart failure stages. In stage C, there is patient with current or previous symptoms or signs of heart failure, while stage D is marked heart failure symptoms that interfere with daily life and with recurrent hospitalizations despite attempts to optimize guideline-directed medical treatment. And this classification also you need to know for class C, that is symptomatic heart failure patient, that is new onset or de novo heart failure, patients having resolution of symptoms which may be with persistent LV dysfunction or resolution of previous structural and or functional heart disease, while patient may have persistent heart failure and worsening heart failure when they are in the stage C heart failure. Now we will discuss the first case, heart failure with reduced ejection fraction. 71-year-old female, hypertensive, diabetic, history of breast cancer before 1 year, and she was treated for that, and she presented with symptoms and signs of heart failure, and ejection fraction showed LVEF of 20%, previously it was 65%. So patient was hospitalized and given IV diuretics to improve symptoms. Coronary angiography done after stabilization which showed the non-obstructive CAD, MRI was practically normal, and the patient was taking treatment, that is metformin and glyburide for diabetes, furosemide, lisinopril, carvedilol and amlodipine. 1 week post discharge, patient was stable hemodynamically, there was no mitral regurgitation, eGFR was 45, HbA1c was 7.2. Now the treatment priorities in this patient is to maintain euvolemia and avoid hypervolemia, optimize medications and emotional psychological support. And we know that for disease modification, there are 4 pillars of treatment in HFrEF, that is ARNI, beta blockers, MRA and SGLT2 inhibitors. So in this patient, we need to switch from AC inhibitors to sacubitril valsartan, and you should remember that you have to stop AC inhibitors 36 to 48 hours before switch. Titrate up beta blockers, add MRA, monitor potassium levels closely after initiation, initiate SGLT2 inhibitors, and optimize medications over a period of time. So this is the diagnostic algorithm for heart failure and EF based classification. When you see that initially clinical assessment, ECG and labs are done, particularly NT-proBNP, and if required you do echocardiography and further investigations like MRI, and the patients are classified as HFrEF, heart failure with mildly reduced EF, and HFpEF, right? And as far as the treatment is concerned, step 1 is in stage C patient, you start with ARNI, beta blocker, MRA, SGLT2 inhibitors and diuretics as needed. If LVEF is improved, then you continue with this GDMD. If not, then the next step will be you can add this hydroxyzine nitrates in particularly African American patients. If less than 35% ejection fraction and more than 1 year survival, ICD may be considered class 1 indication, and in patients who are class 2-3, ambulatory, LVF less than 35 and QRS duration is more than 150 millisecond, you can consider CRT-D. It is again a class 1 indication. Still, if the patient is not responding refractory in selected patients, you can consider durable cardiac support, cardiac transplant and palliative care, which can be initiated even before stage D, and also investigational treatment can be also tried. What about the recommendation about diuretics? Class 1 in patients who are congested, who has got fluid retention, to reduce congestion, improve symptoms and prevent worsening of heart failure. And we use metalazone in some patients who are refractory to the normal diuretics. What about ARNI? They are now class 1 indication in NOIHA class 2-3 symptoms in patients with HFrEF, and AC inhibitors are again class 1 when ARNI is not feasible, right? ARB again it comes after RNA and ACE inhibitors if not tolerated. And in patients with chronic symptomatic HFrEF, this is very important, class 2 or 3, who are tolerating ACE inhibitor and ARB and they are relatively asymptomatic, you have to replace it by RNA to further reduce morbidity and mortality. RNA should not be administered, as we discussed, 36 hours within ACE inhibitors. And RNA is recommended because of this paradigm heart failure trial, which was a very large trial, more than 10,000 patients. And the trial showed that the RNA was superior to enalapril as far as the primary endpoint, death for cardiovascular causes, hospitalization for heart failure, or death from any cause is concerned. And you can see curves are diverging very early, so there was a favorable difference seen very early. Beta blockers, class 1 indications with HFrEF, with current or previous symptoms, and you can use either bisoprolol, carvedilol, or sustained metoprolol succinate. It's very cost effective, and these are the trials. Out of all these trials, Merit-HF has highest number of patients, and they showed a decrease in all-cause mortality as well as hospitalization. Mineralocorticoid receptor antagonist in patients with HFrEF with class 2 to 4 symptoms, it is recommended to reduce morbidity and mortality, but eGFR should be more than 30 and potassium should be less than 5. In patients taking MRA whose potassium cannot be maintained less than 5.5, MRA should be discontinued to avoid the life-threatening arrhythmias. SGLT2 inhibitors, again class 1 indications to reduce hospitalization for heart failure and reduce cardiovascular mortality and mortality. And DAPA-HF was the trial which showed significant decrease in MACE as well as hospitalizations for heart failure, and irrespective of presence or absence of diabetes, the benefit was there with these medications. Now this is very important recommendations that normally what we do is conventional sequencing of initiating of the heart failure therapy by order in which they were tested in clinical trials, and this conventional approach has many limitations. Delay in starting therapy is demonstrated to reduce morbidity and mortality within the first 30 days of treatment initiation, and it assumes that the most effective and well-tolerated treatments were developed first, and it also assumes that foundational treatments are effective only when titrated to target dose. But now they recommend that new expert proposal that treatment with all 4 foundational therapies should occur within 4 weeks, since much of the benefit is seen within first 30 days. And addition of new drug class yields greater benefits than dose titration of existing agents. Moreover, morbidity and mortality is reduced even with the low starting doses. The step 1 is simultaneous initiation of beta blocker and SGLT2 inhibitors, and in next 1 or 2 weeks, step 2 is addition of RNA, and again 1 to 2 weeks you add MRA. So within 4 weeks, all 4 agents should be started. So this is very important, and then you can optimize the dosage as per the tolerance of the patient. Now, these recommendations are very important to remember for patients with HFrEF. When you put ICD, the indication is less than 35% of ejection fraction, and QRS is less than 130. And non-ischemic heart failure, it is class 2A indications, while ischemic heart failure ICD is class 1 indication. Similarly, if ejection fraction is less than 35 and QRS is more than 130, CRT D or P may be planned, and the QRS duration, if it is between 130 to 149, it is class 2 indication, and if it is QRS duration is more than 150, it is class 1 indications. Now second patient is heart failure with preserved ejection fraction, 82 years old lady, and patient has got dyspnea on exertion. She is taking metoprolol, amlodipine, emeril for hypertension and diabetes. No ischemic changes noted on ECG, and echo showed left ventricular hypertrophy, ejection fraction 60%, and signs of diastolic dysfunction. Exercise was done for 2 minutes and 50 seconds only on cruise protocol, and then she had extreme shortness of breath. Blood pressure was 150 to start with. Peak exercise hypertensive response is there, and echocardiography also showed that ejection fractions remained same, or there was a hypercontractile LV, but the RVSP increased to 65. And this is the diagnostic algorithm that we discussed. So patient falls into HFpEF, and the treatment is that patients, if it is hypertensive, then you have to optimize the treatment and blood pressure should be controlled optimally, that is class 1 indication. And SGLT2 inhibitors, they have got class 2A indications in now HFpEF. Also patients with HFpEF, management of AF can be useful to improve the symptoms, while MRA, ARB, ARNI, they are class 2B, slightly lower, as far as the indication is concerned, and use of nitrates are class 3 indication. So diuretics as needed class 1, SGLT2 is class 2A, ARNI, MRA, ARB class 2B indication in HFpEF. And these are the trials. Spironolactone, this showed that there was decrease in composite of death, cardiac death and heart failure hospitalization. Statistically not significant, but heart failure hospitalization was reduced highest by 0.83. And the liver trial was with DAPA, which reduced the combined risk of worsening heart failure and cardiovascular death among patients with heart failure and mildly reduced or preserved ejection fraction, and that led to class 2 indication. And you can see that SGLT2 inhibitors is indicated in all 4 stages of heart failure: stage A, stage B, stage C as well as stage D. And rest of the medicines, as we discussed, you can give 4 pillars, hydrolyzing nitrates if needed, and for with preserved ejection fraction you have got these SGLT2 inhibitors, ARNI, MRA and beta blocker, right? So finally, probably last slide, in additional therapies for patients with heart failure and comorbidities, and here if the patient has got ejection fraction less than 35 and suitable coronary anatomy, you can do surgical revascularization. Patients with heart failure attributable to VHD or cancer therapy, multidisciplinary management. Patients with heart failure and AF, anticoagulation, that is class 1 indications we are talking about. And patients with HFrEF with iron deficiency, now IV iron replacement is class 2A indication. Patient with AF, LVEF less than 50, if rhythm control strategy fails and ventricular rates remain rapid despite medical treatment, AV nodal ablation and CRT implantation may be planned. Patient with heart failure and symptoms attributed to AF, atrial fibrillation ablation should be offered to the patient. And patients with AF with heart failure with obstructive sleep apnea, you may give option of CPAP. So key take home message is guideline directed treatment for heart failure with reduced ejection fraction now includes 4 pillars as we discussed. For SGLT2 have a class of recommendation 2A in heart failure with mildly reduced ejection fraction, and these ARNI, AC inhibitors and MRA has slightly weaker recommendation. Improved LVEF is used to refer those patients with previous HFrEF who now have LVEF more than 40%. And very important to remember that these patients should continue their HFrEF treatment. You should not down titrate the treatment. And evidence supports that increased filling pressure is important for diagnosis of heart failure if LVEF is more than 40%, and evidence of increased filling pressure can be obtained by NT-proBNP or invasive testing or echo findings. Thank you very much.
So I am going to discuss the valvular guideline, what we should remember, what are the salient features which I am going to highlight. This guideline was presented in 2020 by the ACCHH, which is this current version. And when any guideline, when we discuss, we have to remember what is the class 1, class 2A, 2B and 3. Class one means it's absolutely indicated, you should be doing this. Class 2A means it is beneficial, so we should be recommending to the patients. Class 2B means there are evidence that it may not be beneficial, but it may not be harmful also. But class 3 means you should not be doing that intervention or that particular drugs. And level of evidence A, B, C means A is the highest level of evidence present about that particular intervention or the drug based on the multiple control trial, randomized trial and the meta-analysis. And class 3 is the least evidence available. So whenever we see a patient with valvular heart disease, first we evaluate by the history, by the physical examination, we take the help of the ECG and the X-ray, and then we come to a conclusion that patient is having some particular valvular heart disease, and we do the transthoracic echocardiography. And by transthoracic echocardiography, we could find out what is the etiology of the valvular heart disease and what is the extent of the valvular heart disease. For the stenotic lesion, the measurement of the maximum velocity, like maximum gradient, peak gradient, mean gradient, and valve area is important. For the regurgitant lesion, regurgitant orifice area, regurgitant volume, and regurgitant fraction we measure. And along with these measurements, we usually measure the hemodynamics of the patient, whether there is a pulmonary arterial hypertension is there or not, whether there is RV function preserved or not, what is the RV size, and so on. So most of the time we get more information by echocardiography, but sometimes we may need help of some other investigations also, like cardiac MRI. Sometimes we may need cardiac like transthoracic, transesophageal echocardiography. Sometimes we need the PET scan also. But most of the time, for any valvular patient, if they are just following the medical treatment, we can reach on the conclusion based on these investigations. And for sending a patient for prior surgery, like dental evaluation is very, very important. Now there is a ACCHA guideline recommendation that patient is going for valvular surgery or intervention, you should have the oral examination done, and if there is some teeth problem, that has to be sorted out before sending for the surgery. Because this that dental infection has been found to be one infection which can lead to infective endocarditis in a prosthetic valve patient. And all patients going for the valvular surgery should undergo either CT angiography or the coronary angiography. If there is some evidence of obstruction of the CT angiography, again we have to do a conventional angiography. All patients going for TAVI, we need to have the peripheral CT to find out the peripheral vessels, and cardiac CT to find out what is the valve morphology and what are the different parameters to do a proper TAVI procedure. For any valvular, there is a stage. At-risk patient, we call it the stage A, then patient disease progresses stage B, C and D, so on. So if we can pick up the patients at the stage A or B, I think we can prevent the progression of the valvular heart disease. And a patients with the valvular heart disease, whenever you see for the stenotic lesion, if they are asymptomatic, you can follow up every 3 or 5 years. But once the patient becomes symptomatic, then you have to follow patients probably once in a 6 months or once in a year, so that you can send these patients for the intervention at the proper time. And I think this recommendation came after a very long time, like rheumatic prophylaxis in a patient with the rheumatic heart disease, which was recommended long back. So now also the recommendation is same. Whenever the patient has rheumatic fever, the secondary prophylaxis should be up to 10 years or up to the age of 40 years, whichever is later. Like a patient develop rheumatic heart disease at the age of 35, so he should get the secondary prophylaxis till the age of 45. Okay. So, and the prophylaxis can be given in the penicillin, benzathine penicillin, oral penicillin we can give 200 milligram twice daily. Those patients are sensitive to penicillin, can be sulfadazine, can be given 1 gram, and some patients, if they are sensitive, we can give even the azithromycin and so on, macrolides. So, coming to the anticoagulation part in patient with valvular heart disease, it's about the patient with valvular heart disease develop the atrial fibrillation. So all patients should receive the vitamin K antagonist, but those patients with the native valve or a patient underwent the prosthetic valve replacement, after 3 months you can just give the either NOAC or maybe the vitamin K antagonist. So NOAC has come as one of the indication. Post prosthetic valve implantation, after 3 months, the patient can be given either NOAC or can be given the vitamin K antagonist. But for patients who newly develop the atrial fibrillation, they should receive the vitamin K antagonist. So, periodic assessment for all the patients who underwent the aortic or mitral valve replacement is very important. You assess the risk, and each follow up the patient's echo should be done, and estimation of the pulmonary pressure and the RV function, LV function should be done at each stage of the time. So coming to the management of the aortic stenotic part, if patient is having the asymptomatic aortic stenosis, no symptoms, then probably the patients can be managed medically. But only surgery is indicated when the patient is going for other cardiac surgery, like patient is going for CABG. If the asymptomatic AS also we can do or a moderate symptom also we can do the aortic valve replacement along with that. But once the patient is symptom because of the aortic stenosis, the gradient is high, the ejection fraction is still normal, then also you should send the patient for either aortic valve replacement or the TAVI. TAVI age usually is recommended for a very comorbid patient, age more than 80 years, not surgically suitable. Those patients we should be sending for the TAVI, or there one soft indication for TAVI where you feel that patient should need a bioprosthetic valve even after the age of 65 to 80 year of age, patient with a high STS score, you can send those patients also for the TAVI. So surgical AVR and the TAVI, aortic valve replacement again depend upon the comorbidity, STS score, patient frailty, and the indication for sending a patient for a bioprosthetic valve. So patients with the older age comorbidities should we go for TAVI rather than the surgical aortic valve replacement. What about the aortic regurgitation? If it's an acute aortic regurgitation, patient will deteriorate very fast, patient will develop the pulmonary congestion, and you should be sending a patient for early surgery until it's infective endocarditis, otherwise patient can go for the surgery. For the chronic AR, yes, again you have to assess the symptoms. If it's a moderate AR, patient can be followed clinically for so many years, and again it's going for some other cardiac surgery like bypass surgery, then even moderate aortic replacement also can be done. But patient with the symptomatic aortic valve regurgitation, then it's a class 1A indication for the surgery. And if once the patient's LV start reducing, and when the left ventricular ejection fraction start reducing, when the left ventricular ejection systolic dimension start rising, then the patient should go for a surgery. So timing of surgery is very important in the regurgitant lesion. Again, for the mitral stenosis, for just to summarize this, that patients with the mitral stenosis, if valve is pliable, they should go for we call it a BMV, or its a new name is a PMBC. So percutaneous balloon mitral commissurotomy. So if patients valve are pliable, all patients should go for the BMV. Otherwise, if the valve is not pliable, patient is having associated mitral regurgitation, mitral valve replacement can be done. Those patients with moderate mitral stenosis, again they can be very well followed on the medically. What about the mitral regurgitation? The primary mitral regurgitation again depend upon the symptoms. If patient is asymptomatic, again you don't have to do anything, just follow those patient medically and look for the development of the LV dysfunction, look for the dimensions of the left ventricular, and then the left ventricular dimension start rising, then the patient can go for a mitral valve replacement. Otherwise, moderate patients, they don't need to undergo any mitral valve replacement. For the secondary MR, again if patients is MR is because of the annulus dilatation, post myocardial patient severe LV dysfunction, develop mitral regurgitation, these patients can be followed medically. But if patient is going for CABG bypass surgery, and again if patient is having the severe mitral regurgitation, these patients can be sent for the mitral valve replacement or repair also along with the CABG. What about the tricuspid valve? If there is a tricuspid valve regurgitation which is the secondary to the left ventricular pathology, these patients don't need anything. If there is a annulus enlargement, those patients can go for the, along with the left valve surgery, can go with the mitral annular repair surgery. And mitral tricuspid replacement is rarely indicated. Mostly most surgeons don't do the because of the low flow gradient, the valve thrombosis chances are very high. So most of the time we repair the tricuspid valve along with the left ventricular pathology. So what about the combined, like patient with the mitral stenosis along with the MR, along with the AR, along with the AS? If patient is having the MS with MR, then patient can go for MVR. Patient with MS and AR, again AR can be followed clinically, and patient we can do the BMV. If patient with MS and AS asymptomatic, can be followed for years, and then subsequent patient can send for the double valve replacement surgery. Patient with AS and along with the MR, again this combination is very lethal. AS with MR is very lethal combination, so you have to follow this patient very frequently, and if required, those patients can go for the double valve replacement. So decision making is very important. So very important part of this antithrombotic treatment in the prosthetic valve. In the morning also I told that all patients with the prosthetic valve with the AVR, the INR has to be around 2.5, and those with the mitral valve replacement and aortic valve replacement along with the some risk like atrial fibrillation, the INR should be kept around the 3. And if patients indicated or if there is a high risk, you can add on the aspirin along with that. And if patient is going for some non-cardiac surgery, then again you have to do the proper counseling to the patient and put the patient on the appropriate anticoagulant treatment. Patient with the TAVI and patient with the bioprosthetic valve, again, they first 3 months they need a vitamin K antagonist like warfarin and acetone, and then subsequently this patient can be on aspirin alone, or after TAVI also the patient can be aspirin plus clopidogrel. But if patient on TAVI or post aortic valve replacement or bioprosthetic valve replacement develop the atrial fibrillation, again these patients should receive the vitamin K antagonist. So when any patient undergo prosthetic valve implantation, these patients should be very much regularly followed for the bleeding, for the thrombotic event, and for the valve thrombosis. Once the patient develop the thrombotic event on whatever dose patient is on, that means that anticoagulation is not enough for that particular patient. So either you have to add on the aspirin and you increase the therapeutic range for the INR. Like patients is INR is 2 and he developed thrombotic event, so now you have to keep the INR up to 3 along with the aspirin. And those patients who develop the thrombosis, again it's a prosthetic valve, metallic prosthesis, then patient can be given the mechanical thrombolysis, no, first IV thrombolysis. If not recovered, then patient has to go for the mechanical aortic valve or mitral valve replacement. If the patient is having the prosthetic valve like tissue valve, then again we can do the thrombolysis, and require we can do the valve in valve implantation. So prosthetic valve, if the patient develop the infective endocarditis, the management is same as like a native valve infective endocarditis, and we can do based on the culture. But for the patient with the mechanical prosthetic valve develop the severe AS or severe AR, severe MS, severe MR, again repeat surgery is the only option. But those patients who have the prosthetic valve and develop the stenosis or the regurgitation, we can probably do the valve in valve like percutaneous by TAVI or by the TMVR, we can put a valve percutaneously. So patient with the prosthetic tissue valve or the bioprosthetic valve, TAVI and TMVR may be a good option for the future. Management of the native valve in patient, in the pregnant lady, again is very important, because pregnancy is a prothrombotic condition. So patient on having the valvular disease, before becoming pregnant, you have to counsel the patient if there is a severe AS and the severe MS. Like stenotic lesion has to be tackled before the pregnancy. Regurgitant lesion can be tolerated during the pregnancy. So if there is an indication, we have to convince the patient for going for the intervention prior to the pregnancy. Those patients with the MR and AR can be followed medically during the pregnancy. Patient having the prosthetic valve, again it's very much important that you counsel the patient. Best one is to give the warfarin throughout the pregnancy. Just stop the warfarin just before the delivery, and the maternal complication prosthetic valve thrombosis is least in that strategy. But again the second stage can be during the organogenesis, like first 12 weeks you can put a patient on the low molecular heparin, then followed by warfarin, and then at the time of delivery you can switch out the patient to the low molecular heparin. So valve intervention, patient going for the prior PCI or any patient going for the CABG, again any patient going for the CABG, we usually assess, we do the coronary angiography, based on that we decide. But if there is any valvular lesion, if there is a moderate kind of lesion also, we have to do the either valve repair or the valve replacement, and vice versa. If any patient going for valve surgery, we do the coronary angiography, and if there is a moderate to severe lesion, we treat that particular obstetric lesion along with this. So the last one is the patients going for surgery in patient with the atrial fibrillation. Again atrial fibrillation, if patient is having the valvular pathology, the vitamin K antagonist of warfarin is indicated for all the patient. Otherwise, the patient will develop the massive infarction. So this is the last slide. If patient is having a prosthetic valve or patient is having the valvular heart disease, what about the non-cardiac surgery? So if there is a severe valve pathology, stenotic lesion with symptoms, probably elective surgery should not be done. The patient, this valvular lesion or problem should be tackled before. But if patient is having asymptomatic, either it's a stenotic lesion with normal PA pressure, those patients can safely go for a non-cardiac surgery. Or if patient with asymptomatic with regurgitant lesion, again these patients can be very well tackled with the non-cardiac surgery can be done before taking the valvular surgery. So I finish here. I thank you for these slides. All slides are taken from the ACC-AHA guideline, and I thank you for all the patients listening. Thank you so much.
So it's a more of a clinical case only. There is nothing too much of theory. So just I think your sleep may go away with this. So start thinking. 46-year-old male, non-smoker, non-hypertensive, works about 20 minutes per day, 5 days a week. BMI is 28. Is diabetic since 6 years. HbA1c is 7. He is on metformin 500 BD. He has no angina. TMT is normal. Father had angioplasty at age of 50. This is his lipid profile. Cholesterol 170, LDL 70, HDL 30, triglyceride 200. So patient is anxious about his cardiac disease. What will you suggest? Because father had early age angioplasty. This fellow is diabetics. So he is worried. So what will you suggest? You can shout or tell your opinion. Will you do CAG to rule out coronary artery disease? Will you do some CT calcium score or LPA or carotid intima media thickness, or you will just reassure TMT is normal, your diabetes is okay, BP is normal, non-smoker, you are working also. So just reassure. What will you do?
He is just 4 years away from his father's MI age.
So what is consensus? 2. Out of 3, which one? No, LPA? No, there are 3 options. CP, CSE, lipoprotein small a and carotid. Okay, fine. Okay, we'll go ahead. So what will you do for lipid? No, that is okay. That will be at the end. That question's answer will be at the end. So what you will do for lipid? Will you add niacin? This cholesterol, lipid profile is there on the right corner. Add niacin, statin, saroglitazar. He has diabetic dyslipidemia, fenofibrate, fish oil, or no drug. Just review after 6 months. So you will add statin. So treating physician actually increase walking. You are slightly overweight. Increase walking also. So from 20 minutes to 40 minutes a day. DAPA was added. His BMI is 28, so he is by definition is obese. And his normal BMI is 23 for Indians, 23 to 27 is overweight, more than 27 is obese. So he is actually obese. So DAPA is added, so it's good actually, because HbA1c also young patient, you may try to keep less than 7. And as somebody suggested, he has diabetic dyslipidemia, triglyceride is 200, HDL is low, so added fenofibrate. So after 1 year, his BMI is reduced from 28 to 25. So it was good, DAPA had worked. And of course he had increased his walking and exercise also. HbA1c also is better now. 7 has become 6.6. Fenofibrate 200 mg per day is going on, and his lipid has improved. Total cholesterol now 160, LDL 66, HDL 34, triglyceride 200 has become 140. So are you okay? Are you satisfied? No. So what do you want to do? Pardon? HDL. HDL is low. How to increase HDL? I also don't know. There is hardly any drug which is actually increasing HDL. He can increase walking. That is the good thing. He can have walnut and other things. PCSK9. Somebody told. His TMT is normal, he is asymptomatic, he is non-smoker, diabetes is well controlled, and directly PCSK9. Anybody has any suggestion, or are you okay? Statin is a suggestion, good suggestion, okay. Pardon? Statin with ezetimibe. So what is your, what is your aim? Reduce LDL. Yeah, that is good. By 40%. It was 70. You want to reduce by 40%. Okay, good. So he was on pilgrimage and got chest pain. This is the ECG. So incidentally, it was a small place. He could receive even streptokinase after 2 hours, and he had persistent chest pain. So he was shifted to cath lab in another city. After 6 hours, angioplasty could be done, life could be saved. He was stabilized. Ejection fraction is down to 35% now. So what went wrong? He came to you well in time. He was very anxious. He told also that, sir, I am afraid of heart disease. You do something for me. And he was ready to accept whatever you advise. So you advise fenofibrate, you advise dapagliflozin, and this is the present scenario. So what went wrong? Any suggestion? Carrying calcium score. Suppose it was done, and it was, say, around 50 or 100. Then you are right, actually, something has gone wrong, and let us try to analyze where we went wrong. So basically, once patient has diabetes, actually, it increases your risk of cardiac event or cerebral event by almost 2 to 3 fold. So that is one thing. So our patient we did not assess his atherosclerotic cardiovascular disease risk. So actually, we should always try to think that where is he standing? Because according to this risk, we have to decide LDL goal. That is the basic thing for any patient. So, what do you think? What is this atherosclerotic cardiovascular disease risk? Low, moderate, high, or very high? Why high? So this is the guideline, Lipid Association of Indian guideline. So this is our patient clinical scenario on the right upper corner. Now what you have to do is always assess major risk factors. So there are five criteria. Age more than 45 for male and for female 55. Our patient is 46, so one risk factor is added. Family history of premature coronary disease is there. Father had angioplasty at age of 50. So father having CAD or coronary event less than 55 and mother having age less than 65 is another risk factor. So our patient had 2 risk factors. Current smoking, no. High blood pressure, no. Is low HDL. If HDL in male less than 40 and in female less than 50 is again a major risk factor. So our patient already had 3 risk factors. So always try to assess like this. Patient requiring risk assessment, count number of major risk factors. So our patient has 3 risk factors, so he is high risk factor. Plus you have to look at other risk factors, right lower corner. So if you have diabetes with one major risk factor or no evidence of target organ damage, then you are in very high risk category. So very high risk category means what? Diabetes with 2 major atherosclerotic cardiovascular risk factor or evidence of target organ damage. Patient has no target organ damage, but he has not 2 but even 3 major risk factors. So this is the guideline. So if you have high risk category, your LDL goal is 70. But if you are very high risk category, your LDL goal is less than 50. So our patients' LDL goal was less than 50. Initially at the presentation it was 70 and then it was reduced to 66 after treatment. But target was 50. And not only that, actually we forget to look at the co-primary target. What is co-primary target for Indians? Non-HDL cholesterol. It is equally important. You don't have to look only at LDL. Look at non-HDL cholesterol, that is total cholesterol minus HDL. So our patient's non-HDL cholesterol was 170 minus 30, that is 140. And after initial treatment, it reduced to 126. What was the goal? Goal was 80. So he was far, far away. LDL was still okay, but HDL wise, non-HDL cholesterol wise, he was far, far away. So, as somebody rightly pointed out, LDL was the target and it should have been the lowest, and lowest is the best, we know it. And we know that there is incremental benefit of lowering LDL below 70. So 70 is still okay, but if you go below 70, you do even better. Your risk continuously goes on decreasing. And our patient is at very high risk, so our goal was around 50. And that is what ESC guideline also says. ESC guideline says 55, Indian guideline says 50. And not only LDL goal is important, it is cumulative exposure to LDL which is more important. And that cumulative exposure to LDL starts from the day 1 of life. So suppose somebody is, and there is what we call cumulative LDL exposure of, that is milligram years over years. So suppose somebody's LDL was 125, then he crosses this cumulative LDL exposure threshold, that is 5,000, at around 40 years of age, and at around age of 60, he may get myocardial infarction. So if you are keeping your LDL throughout your life by 125, then you may get atheroma or atherosclerotic disease by age of 40, and you may get SCS or MI by age of 60. Instead of that, if you try to keep your LDL around 80 since early childhood, then you may develop that cumulative LDL exposure threshold is crossed by, that threshold is 5,000 and that is crossed at around 65 years of age, and you may get coronary event at around 100 years of age. But instead of that, suppose your LDL was too high, around 200, then he may get, he will cross the threshold at around 20 years of age, and by early 30s, 35, he may get MI, a first event. So it is LDL, cumulative LDL exposure, that is more important. So not only LDL per se, not only LDL goal, but how many years you allowed that LDL to remain high, that is to be emphasized, and that is very, very important. આપણને કંઈ થશે ત્યારે જોયું જ હશે, બાકી અત્યારે તો હજી ચાલે છે ને 80-90 છે, બધું ચાલે છે, કંઈ મને તકલીફ નથી, so that is the wrong concept. Earlier you bring down your LDL in your lifespan, you may live longer. And how to do that? See, if you give high intensity statin, you are reducing LDL by 50%. But if you add azithromycin, you are reducing it by 65%. You give PCSK9 inhibitor alone with statin, you are reducing by 60%. Means PCSK9 plus LDL, statin 75%, and if you combine all three, then 85%. Of course, PCSK9 is too costly. At least add azithromycin in all. So statin plus azithromycin, you go to maximum dose, you will get at least 65% reduction. So what should have been done in our patient? He should have exercised more. He is obese, so metformin was added. You can increase metformin. DAPA was already added. Statin should have been added on day 1 of diagnosis of diabetes. So actually, regardless of LDL level, once you are diagnosing anybody having diabetes, statin should be there on day 1 of your diagnosis. You do lipid profile, that will help you to give the dose of statin, whether you want to give 10 milligram, 40 or 80 milligram of atorvastatin, but 10 milligram should be there on day 1 of diagnosis of diabetes. So this fellow should have been on statin from day 1. It was not given till he got MI1. And he is in very high risk category. His non-HDL target was 80, so somebody should have started on rosuvastatin 40 or atorvastatin 80. And if not at goal, maybe in 2-3 months, ezetimibe should have been added. As we discussed that he was anxious about having heart disease, what should have been done? Everybody agreed that 2 is the correct answer. Agree. You should try to look at other high-risk features. So he is already diabetes, but you should try to see he has no CKD, he has no familial hypercholesterolemia, but you can always do colonic calcium score, you can do carotid intima media measurement, or you can check lipoprotein. If this risk factor is there, any of these, then again he is in very high risk category. From high risk, he goes to very high risk. Our patient, because of presence of diabetes, he was already in very high risk category, but this could have further emphasized the risk category and further emphasize the need for very low LDL, that is 50 from day 1. So everything was missed. Even 10 milligram of statin was also not there. So you should do any of this calcium score. So any calcium score more than 300 is a risk factor. 0 to 300 is still okay. It is an indication for statin and aspirin. But I mean, you should not go for direct angiography in an asymptomatic patient. Calcium score gives you or emphasizes that he needs aggressive risk factor control, and it doesn't need that you should go for angiography. That is a wrong notion actually. So you should have undergone this thing. Thank you.